Empezamos entonces con este apasionante tema. We will begin now with this amazing theme. First time, what is fear? Fear is only less knowledge. Although you study, more knowledge, less fear. So in this little bit of course, we will try to give to you all the skills not to have more fears in your room. First of all, the most important thing to understand is that the diagnosis how to decide to do an ECG, we must have 70% of the diagnosis in the oral report. You must take the age of the patient because it's not the same to have 13 years old or to have 70 years old. The gender of the patient, the morbidity, because if it's a person who have no illness or is a person with diabetic, hypertension, that is different. The medication is taken because some medication sometimes produce tachyarrhythmias, and another medication produce decrease of the rate of the heart. So for that reason, it's very, very, very important to take the morbidity of the patient. Yeah, the chief complaint. Why he's coming to our hospital? He's coming for abdominal pain, for vomiting, or is coming for chest pain with abdominal pain or vomiting. These symptoms are very, very important. We must ask to the patient the localization of the symptom, if it's in the chest, if it's in the back, if it's in the abdomen. The beginning is not the same illness if the patient was doing an effort and the chest pain begin, or if the chest pain wake up the patient when he was sleeping. From where is going the pain, the intensity of the pain, the character, because it's not the same to be one pain finger. That means when the patient tell you, where you ask the patient, where is the pain? And the patient say, here. This is a one pain finger. That means that the pain is in muscle or in bones, not visceral. But when the patient tell you, the pain is here with all the whole hand, that means that is a visceral localization, maybe a pain in the heart. What other elements are for pain? For example, is sweating, is vomiting, have cold extremities. For that reason, is very important. The second part of the diagnosis will be with the physical examination. We must examine the patients, because when we examine the patient, we can find, for example, that have epigastric pain, but that have a bone or a muscular pain, or we can examine the patient and we can detect an arrhythmia. So for that reason, the second part, 70% of the diagnosis is oral report. Ask the patient. The 10% is physical examination. The other 10% is laboratories, troponin T, CKMB, and the other 10% is the ECG. So if you are in your room and you want to ask the specialist about an ECG, you must give all of these: age, gender, morbidity, medication, shift complaint, symptom, localization, beginning, propagation, intensity, character, and other elements with the pain. Because if you send to the specialist or to the consultant only the ECG, you are sending the 10% of the information. According? Let's go on. Another important thing, and this for all our beautiful nurses, is how to put the limbs leads, because it's very, very important, because you will see that all the ECG have a point where an specification, right arm, left arm, RL means right leg, LL means left leg. So you must put the electrode and the cable of right arm, electrode right arm, cable right arm. That is important, because sometimes we have some waves that are not correct in the ECG. Yeah, and this is a mistake of the position of the leads. Another important, very important thing is to put the precordial leads. What's happened? We must search first the four thorax space, intercostal space, and we will put there in the para-external line, in the right para-external line, B1. B2 maybe in the left para-external line for intercostal space. B4 maybe in the fifth intercostal space, B6, B5 beside line, axillary anterior line, and B6 axillary middle line. And B3 is between B2 and B3. These are the precordial leads, the normal precordial leads, the standard precordial leads. But when we have ischemic cardiopathy, if we have a chest pain, typical chest pain, we are suspecting myocardial infarct, we must take the right precordial leads also. And how we will put this right precordial leads, my beautiful nurse? B1 is in the same position, B2 in the same position. You don't move that leads, but you will put B4 right, B5 right, and B6 right in the 5th intercostal space in the right side, and B3 between B2 and B4. So it's the same position that you have to the left part, the same position you will have to the right part to put the right precordial leads. Understand? If not understand, please send us the question. No problem, we will answer everything. The other important thing is the posterior leads, because when you put the posterior leads, maybe you will find there an ST elevation, and that is crucial for the diagnosis and treatment. So the posterior leads you will put with the patient in the part of V7 will be in the axillary posterior line, B7 will be in the scapular line, and B9 will be in the paravertebral line. But the patient can't be back. Maybe the patient, you must give a little rotation to the patient to put these leads. And these leads, as you can see here, are very, very, very important to see the posterior part of the right or of the left ventricle. So sometimes in B1, B2, B3, we have mirror change. What's mean mirror change? That we have an ST down. Yeah. So you will see and you will think that is a non-STEMI infarct, because ECT is a decrease. You decrease the ECT. But when you do the posterior leads, you can see that in the posterior lead there is an ST elevation. So you must thrombolytize this patient. But if you don't do the posterior lead, you will think that this patient is only an unstable angina or a non-STEMI infarct. So you will admit in our ICU, and we will do emergency referral. But in 12 hours or 24 hours, this patient will be critical because really have an ST elevation in the posterior legs that we don't see because we don't do the right or the posterior legs. That's the very, very important to do all the leads when we have coronary pathology. So what is fear? Fear is a false evidence that appears real. We must take off this false evidence doing all the leads in our patient when we suspect or have that have an ischemic heart disease. So now we will see what are the basic points of the ECG paper, because the paper is special. The paper have a little square, and this little square is 1 millimeter in the horizontal leads and 1 millimeter in the vertical leads. That's right. But what does mean? That means that when the paper is going on 25 millimeters per second, this paper, this small square, the time that with pulse is 0.04 seconds. So if we have 5 little square, we will have 0.2 seconds. And in the vertical part, if each square is a small square is 0.1 millivolts, 5 squares 0.5, and 2 bigger squares 1 millivolts. This is only to know because sometimes we must know these measures to see when we see the waves, the P waves, the QRS waves, etc. What happens when we have an ECG? We must do a correct interpretation, but first we must know that is the electric impulse of the heart that is testing the ECG. So where do this begin? This begin in the sinoatrial node. So the impulse of the sinoatrial node will produce first the despolarization of the left atrial. Of the right atrial, and then the depolarization of the left atrial. So the first part of the P wave will be the right atrial, and the second part will be the left atrial. Then the impulse stop here in the bundle his. So stop the impulse. So we have the PQ segment, and then come from all the left and the right bundle branch. So we will have there the contraction of the heart. When we have the contraction of the heart, we will have in the ECG QRS. Then we have again and stop, and this is an ST segment, and the repolarization will begin, so we will have the G wave. That are the parts of the ECG that are showing how is the contractility of our heart. What happened? The first wave we will find in the ECG is the P wave. Yeah, I told you that the P wave, the first part is the right atrial, the second part is the left atrial. But there's a very interesting point here that you must see. If the P wave is positive in D1, in D2, and negative in AVR, halas, this ECG is well done. If the P waves don't have these characteristics, please tell the nurse to do the ECG again because she changed the leads. So that is a very important point. And the P waves have an interval between the beginning and the finish that is 120 or 200 milliseconds. That means 3 and 5 small squares. Not necessary to know all the time, but we must know the square. The P wave is 3 to 5 small square. Yeah, if it's more, we must think that it is a block. And if it's smaller, we must think that there is an anomal as like word Parkinson White. What other characteristics have this P? Look at this P. This P is very, very tall. It's more than 2.5 millimeters. So we must think that this patient, the right component of the atrial is big. So maybe a bronchial asthma, maybe a smoker, maybe a COPD. Look at this. Here we have the pulmonary component, but also we can see the left atrial component very well, and also the P wave is more than 3 millimeters. Yeah, that is showing that we have a bilateral increase of the atrials, right and left, maybe a heart failure, maybe a mitral insufficiency, something like that. Yeah. Also, we can see sometimes that we have a biphasic P with the mitral component very, very negative. And sometimes in some tachyarrhythmia, we can see the P wave, but not before the QRS. We can see the P wave inside the QRS. That is an anomal ring. So to see the P wave will show us a lot of diagnosis. What else we will see in the ECG interpretation? Okay, we will see the rate. What's happening with the rate? We must see the big squares, not the small square, but the big square. When we see the big square, we can see that the rate is 300 in the first line of the big square. The next big square will be 150, the next 100, the next 75, the next 60, and the next 50. So this is a fast skill to know the rate of the heart in ear room. And I will show you. Here we have QRS in the big line of the big square. So this is 300. The next is 150. The next is 100. The next is 75, and the next is 60. So this QRS is between 60 and 75. Yeah? So now we count like this. 71, 2, 3, 4, 5. At least this rate is 68. So the first one is 300. The second is 150, the third is 100, the fourth is 75, and the last one is 60. The QRS is between 60 and 75. So the rate is normal. What else we will see? We will see the rim. What happened? We must know if the rim is normal or abnormal. A normal rim is when we have the first impulse in the atrial nodule. So we must ask ourselves, here is the ECG. Are the P wave present? Yes, P, here P, all the P waves are present. Second question, is there a P wave before every QRS complex and a QRS complex after every P wave? Yes, P wave, QRS, P wave, QRS complex, P wave, QRS complex. Are the P waves and QRS regular? Yes, we can see that between this and this, 1, 2, 3, 4, 5 squares. Between this and this, 1, 2, 3, 4, 5 square. The QRS is regular. Yeah? And is the peer interval constant? 1, 2, 3. Here, 1, 2, 3, constant. So the answer is yes to all these questions. This is a normal sinus ring. These are the characteristics. Is P wave, QRS after every P wave, a constant distance between the QRS and constant distance in the PR interval. So that's the characteristics of a normal sinus ring. What happened here? Here is there a P wave? We can find the P wave. This is the T. This is maybe a P, but not a good appearance of P. Here we don't have P wave also. So this rings is irregular because here between this QRS and this QRS, 1, 2, 3. But between this QRS and this QRS, 1, 2, 3, 4. So it's irregular. This is an atrial fibrillation. And here we can see that also is irregular, but we have a component like maybe in appearance of P, but here we can see if it's P, if it's T, but is an appearance. So this is a atrial flutter and atrial fibrillation. Yeah, in here we don't have P wave. We don't have QRS after P because we don't have key, and the QRS between the QRS and QRS not regular. So this is not a sinus ring. The next part we must see in the ECG is the ACEs. Because when we examine the QRS, we must examine in two leads, in D1 and in AVF. If it's positive in D1 and positive in AVF, that means that the axis is normal. This heart is normal. But if it's positive in D1 and negative in AVF, this is a left axis deviation. So the heart axis is more to the left part. What is happening with this patient? The left ventricle may be with a hypertrophy, with dilatation, maybe a myocarditis. So something is happening in this heart. Now, if we have in D1 positive QRS, and in AV and in AVA, in D1 negative QRS and in AVF positive QRS, so we must see in right atrial deviation, maybe an EPOC, bronchial asthma, or maybe a pulmonary thromboembolism or a Q or a core pulmonary syndrome. So we must think in that sense, because the right side is the heart is deviation to the right side. Another thing, important thing, is to see how much is the QRS. For example, if it's white like this, white QRS, we must think in a block. In another module, we will see all the blocks. If it's narrow QRS, we must see the interval, yeah, what is happening. And the normal QRS is between two or three small squares. Also, we must see the airway progression, because Here in B1, we have a negative R, that is normal. But then the negative is turning more and more positive, and in the lateral leads, we have very positive. This is a normal wave progression. But sometimes we will see that from negative pass to positive suddenly. So that is a bad progression of the QRS. So it's showing that something is happening in the heart. In this ECG, we have a very important sign. And you can see there is P, there is QRS after P, but something is happening with the QRS. One QRS is tallest, the other is small, the other tall again, the other is small, 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 tall, small, tall. This alteration of the millimeters of the QRS is showing us that something is happening. Something is in movement outside the heart. So this is characteristic of a pericardial effusion, the alteration of amplitude of the QRS. So we see the rate, we see the rim, we see the axis, and now we will see the morphology of the waves. In this morphology of the waves, one of the important points is the J point, because the J point is where when the QRS finish and when the repolarization beginning before the T wave. Sometimes this is the most important part where the ischemic heart disease will be appear. But we must know what is normal in this segment and what is abnormal. What is normal? It's normal that this segment is in the same line of the PR wave. It's normal that this ST segment is three squares from the QRS to the T. It's normal that the T wave have a very fast up in the first part and then decrease slow because the T wave is asymmetric. That is another point. When we see symmetric T waves, we must think in ischemic cardiopathy. This is normal. Yeah. And now we will see what happened in the abnormal part. Sometimes we have patients which are young, which are good, we have atypical chest pain, and when we do the ECG, we find this, a concavity in some leads. This concavity and this up of the ECT, this elevation of the ECT with a concavity in a lot of leads may be early transition. So that is not a pathologic sign. It's a normal sign of a heart that have early transition pattern. What else we will find? We can find a concave elevation also, but in a lot of leads, in generalized leads. Or we also, this with chest pain, atypical chest pain, we must think in pericarditis. The other differential diagnosis that we must know in this part of the segment is in the ST segment is this wave, the Osborne wave, that is more frequent than you think. In our hospital, we have sometimes this ECG with all Osborne wave because of the drowsy patients, yeah, who come with hypothermia. So this Osborne wave is the QRS with a concavity, an up concavity, but here have this small wave that is the Osborne wave. So we must do the differential diagnosis of this. So the ECT elevation with up concavity may be early patron, maybe pericarditis, maybe Osborne wave. We must join with the report. Who is our patient? What is our patient doing, thinking, etc. So, in conclusion, here I put the ECG normal values. The heart rate is between 60 and 100. The PR intervals is between 0.12 up to 0.20. The QRS interval is less than 0.12. The QT interval in males is less than 0.4 and 0.44 in females. The P waves is less than 3 millivolts, and the P wave terminal negative deflation in LED B1 is less than 1 millivolts. Yeah. So now, when we have an ECG, we can know what is normal. We can think what is abnormal, and we will have some skill to keep our attention to abnormal ECG. So no more fear in the ER room. Now we are a lion. Thank you very much. And if you have some question, can send to us. We will answer.